2022. The time is 1:32 p.m. This is a special meeting agenda sponsored by Human Resource Department with our consultant Alliant Employee Benefits. And attending our commissioners Duncan Brooks and Filios. Do we have any changes to the agenda? I hear of none. So what I'm going to do is, Sylvia, would you introduce our guests? Obviously, we know Scott. And first item on the agenda, by the way, is the overview of the PMR healthcare services for direct primary care in the near-site clinic proposal. Go ahead, Sylvia.
Okay, Scott's going to go ahead.
Oh, can you put your microphone on?
Yes.
Thank you.
See, Scott and I just talked about it, and then I didn't do it. Scott's going to go ahead and handle introductions for us.
Okay.
Hi, Scott Burkhart with Alliant. Today we wanted to introduce two emerging trends in the benefit industry. The first is PMR healthcare, Todd Fouché. It's a near-site clinic model. There is significant possible return on investment, but it's also a significant commitment up front. So with PMR specifically, we want Todd to go through the model. We'll save some time for some Q&A and then ask you how you would like us to proceed best in vetting this going forward. It's not a simple one meeting and then make a recommendation. It's a little more elaborate than that. The second presentation I'll go ahead and introduce now is Edison Healthcare, Sean Rutledge. That's more on the back end, centers of excellence, tourism for major surgeries, transplants, things like that. There's also significant investment on that, but and significant return, but it's not as elaborate as the PMR model. So with that, I'm going to turn it over to Todd Fouché. Oh, and I'm sorry. Adrian Washington is taking David Smith's place today. He's new with our underwriting team at Alliant.
Okay, welcome.
Thank you so much. David was off doing something David-ish, so. But he'll be here at the July, both Adrian and David will be here, I think, at the July 13th meeting. So.
Okay, go right ahead.
Good afternoon, all. I tried to keep this as high level but as detailed as I possibly could, so I'm going to move through quickly for purposes of allowing time for Q&A, but certainly if I need to slow down or back up, I don't ask anyone to hesitate and let me know, but pleasure to be here. I am an Easterner, so it took me quite a ways to come out, but Boise and Coeur d'Alene have been some of my visits for the last couple of years, so it's beautiful country, so it's good to be back. And Dorothy, I just learned retired, so I wish you well, Dorothy.
He's retiring.
Let's see. Move through. Who is PMR? PMR, we are an employer-based clinic operator, so basically since 2005, we have been introducing employer-based clinic models to employers across the country and actually on 5 different continents. We are a privately held company. We have a national and global footprint. We actually have clinics on 5 continents, sub-Saharan Africa. It's just wherever domestic companies have taken us is what's generated the global footprint. The model can vary from being on-site, envision a space about a third of the size of this room where it's a doctor's office visit that's built out, or it's near site where it could be space leased across the street or down the road, for example. Generally, we look at the census of your participants on your health plan to identify what location might create the most access by your employees and the dependents on the plan. Mobile units, actually here in Coeur d'Alene, we're working with an employer that has literally taken a bus and has built it out to be a physician's office, and it travels to each of their locations, for example. And then we combine it with telehealth services because there's always going to be some employees that need services after a doctor's office is closed, or they might be a handful of employees in a remote location in the county where it's not as easy to access. I'm going to talk a little bit about the continuum of care. When we talk about primary care, one of the greatest problems truly across the country is access to primary care. Your county here is not exempt from that. Actually, it's very tight right at the moment. I was in a meeting earlier this morning and it was talking about just the provider community at large, about how short-staffed it is right at present. So when they're short-staffed, it's difficult for members to get access to primary care. So we have a tendency to use the emergency room or urgent care centers for those needs. When I talk about root cause medicine, the focus is, why are you hypertensive? not just give you a medication. Why are you pre-diabetic or diabetic? And try to reverse or improve that, not just once again give a pill to fix everything. So when I talk about root cause medicine, it's trying to identify the root causes of your ailment or prevent your condition from progressing to the more costly stage. Down on the far right corner, when I go to wellness, it's hard to think about wellness when there's so many chronic conditions going on. Many folks are ready to just address the immediate problem before they can think about wellness and prevention. This model is trying to address the entire continuum in the scope of care. Lifestyle, once again, we have a tendency to be stressed, we have a tendency to get lack of sleep, we have a tendency not to eat well. All of these things that we intuitively know but contribute to actually poor health. Specialty services, post-COVID, clinic model can include physical therapy, it can include mental health professionals. These are all very specific to what the membership needs. What you need versus other employers in the community might look totally different. So I wanted to plant the seed. It's very common for us to bring in other specialists into the primary care setting. Workers' compensation, the clinic can also treat any worksite injuries that occur. The goal would be to keep them in a first aid category, not recordable, get the employee back to work, not prematurely, but at the appropriate time, modified work duty, and then if there's any type of pre-employment testing that's being done for new hires, drug and alcohol testing of that nature, ergonomic reviews, all of this entire continuum of services can be provided in an on-site or near-site clinic model. For the county, we started out defining the objectives with Scott and his team's help. We're looking at about 763 employees and the dependents that you see there. That's the approximate membership that we would need to provide care to. When we did that, we took the claims and pharmacy data for your membership for the last 2 years and actually was able to review that by a clinical team. That clinical team literally was looking for how much of the care that was rendered to your employees in the last 2 years could have been done in an on-site or near-site clinic setting versus the setting that it was received in and what was billed to your plan. In doing so, I'm going to go back to that slide. When I look at the bottom there on the far right, 2020, if that combined spends about $9.6 million, you go up to 2021 and we're looking at about $10.6 million. So those are big jumps in my mind for any employer. Down at the bottom there, we created a proposal here, so I'm only going to give the very highlights of that proposal. It's a 40-page document, so perhaps with your benefits team, we could go down into much more detail, but certainly won't have time. The results actually showed us that if we took the medical claims and the pharmaceutical spend for the last 2 years, identified going forward what most likely would happen based on the medical conditions that we reviewed by the clinical folks, by the cost of care, what's happening to medical inflation in your community, not east of the Mississippi, but here, that care that could have been done in the clinic, care that could have been done in a non-urgent care setting, care that would have helped a diabetic maintain and not get worse, things of that example, that we literally, the dollars associated with that would have been about $753,000. I mean, it's down to the penny from the clinical review as to what it would have meant to the county had the model such as that been in place.
And that's after factoring the actual costs of the program,
Yeah.
correct? Yeah.
That would actually, so our fee to staff and manage the clinic with physician and the medical team, that is the savings after the cost of that team providing the care. So it is net, the fees.
And that's not also assuming that everybody in the county is going to use it. That's using a reasonable utilization
Yeah,
model.
and thank you for that. The assumption when the clinical team, when they reviewed your data, there were thousands of lines of data. So every office visit, every lab, every diagnostic, every surgery was itemized. When that clinical team reviewed that, they then have to make an assumption how many of your employees would actually use the clinic. We estimated about 40% to be conservative would use the clinic. You have north of 53% of your employees that do not appear to have a primary care relationship. So 53% is a pretty high number. I don't always see that. I can see it sometimes range anywhere from 25 to about 55%, but it certainly is on the high end. So where do they go when they need care? They might see a specialist for care, they might see an urgent care, ER, et cetera. So those are much more expensive ways to get primary care than actually having a doctor that would be available. So what this slide is trying to show is that all fees to administer the clinic are built into the new numbers, and the savings would be net that. It is, as Scott said, projecting a conservative utilization. It's about estimated in year one, 40% of your employees. We conservatively estimated about 25% of the dependents in the first year would use the clinic. And even at that conservative estimate, it's netting about $753,000 to the county plan. The recommendation was to do a near site versus on-site, just looking at the census of your employees and where they are located. Where are these spouses located? Spouses are generally better utilizers of healthcare, so where are they located? Where would it make sense? So our team on a near site would actually go vet the market as to where there would be space to lease to put in a physician's office. Or if there was a physician clinic here in the county that closed recently, we might reopen that clinic just to take advantage of the setting. It is a physician versus a nurse practitioner or a physician assistant. It's identified. You have roughly about 1,700 belly buttons that was on that prior chart. That 1,700 belly buttons is about ideal for us. We usually do about 1,800 patients to every doctor, but in the county, the relationship is generally about 2,400 patients to every doctor. So it's trying to have more dedicated time with patients versus only being able to see you for 5 minutes and then on to the next step. There would be a nurse, 2 medical assistants, and a doctor would be what's built into our fees to service those 1,700 belly button. The services include primary care and urgent care. Primary care is having extended time with a primary care physician, not 5 minutes, but the appointments are 20, 40, or 60-minute appointments, depending upon how much time you need. It's about expanding women's health. There is certainly an issue that we could see from the clinical data of the lack of women's treatment going on. I'll be able to get into detail with the benefits team to go into what some of that was. The occupational health and support, if there's worksite injuries, things of that nature, I don't want to lose sight of that because sometimes the savings is as great on the work comp side as it is on the primary care health side. And then pharmaceuticals. This clinic actually has a dispensary. There would be medications in the clinic behind lock and key, no narcotics, and they are dispensed at no out-of-pocket to the employee or their family member. So when a person accesses care at one of the near-site clinics, they pay no copay or deductible for the primary care, for their lab services, for their pharmaceutical. It's all done right there, self-contained in the setting. I'm going to speed up just here a little bit. I've got a little bit of a delay there, so bear with me. This is an example if we leased space in your community. It might be some freestanding facility that looks like that on the left, and then on the right, it is your doctor's office. Our fee is set up as a one-time fee. Envision if this was an empty structure. We came in, it takes about 1/3 of this amount of space to have an exam room, intake room, that type of thing for a doctor's office. And it was vacant, 4 walls. It would take a one-time fee for us to bring the necessary medical supplies and equipment to set that physician's office up. So your exam table, your lighting, the medical supplies, that's what the one-time setup fee is. The monthly fee that's there in the middle is what we charge on a monthly basis to provide the care. So when I mentioned 40% of the employees or 25% of the dependents, it is that physician's care, that nurse's care, the medical supplies, everything they do is rolled into a monthly fee, okay? And then on the bottom right, the second monthly fee is that any pharmaceutical that's dispensed, it's on a per-use basis. So if the 4 of you were to have a medication dispensed, there would be 4 medications that would be billed for that month, okay? The fees, I wanted to make a note, when PMR bills its monthly fees, envision any of the care that comes to the primary care clinic, any labs, doctor's visit, pharmacy that's dispensed, is services not being billed to your Blue Cross plan today. So you would see your monthly bill on the Blue Cross side go down because all of the care, and the more care we render through the clinic, the less this is being billed, and the services we're rendering in the clinic, we will show you on the reports that we give, every line item of service, we will compare it to what that same charge would have been had it gone through the Blue Cross plan, you'd be able to see the delta on every single line item as to where the savings comes from. So you should see lab services less than what would have been billed through the plan. You would have seen pharmaceutical expenses less on a per unit basis than what was being billed through the PBM on your plan.
The monthly fees are fixed though, correct, for a
They are.
year?
They are.
It's not variable, like the self-funded plan is gonna go up and down based on actual utilization. These are fixed.
Yeah.
Month to month, so you know what your risk is there.
Yeah, it would be allowing you to budget. And the reason, once again, I mentioned that audit that was done by a clinical team, using those conservative 40% for employees and that's how we're backing into what that monthly fee would be. And it behooves us not to set it so high, because if we set it too high, we can't show you hard dollar savings. So we're equally as motivated to setting the monthly fee. It does have a margin in it. We are a for-profit company. It has a reasonable margin. Our margins are single digit. So I think, that could be relative and understanding, but it is our fee, relative single-digit margin that's built into that, still less than what's being billed through the plan today through the public-private sector.
Okay. And I'll add too, this is not a replacement of Regents Blue Shield, this is a plug-in.
Yeah.
Okay, both models that we're talking about.
We work side by
So we
side.
don't have to change vendors. It's the nice thing about Regents is they play well in the sandbox with vendors like this. And they'll help coordinate all of it for us. So, but this is not actually billed through Regents. They'll just work with them on case management, referrals, things like that. So
we work with Blue Cross plans across the country. So much to Scott's point, the goal is that if we can provide access to about 53% of your population that does not have primary care physicians today, that we provide access to them. If they try to call a doctor's office for a primary care visit today, it might be 2, 3, 4 weeks, if the doctor even has capacity. So this is a medical team that's solely dedicated to your base, to improving health, reducing the cost, less use of ER, manage your chronic conditions. Your spend that went up $1 million, there are a lot of chronic conditions there. We can see that individuals are not compliant necessarily with their diabetes regimen or their cardiac regimens and that. You can see it in the data. Women's health, once again, was one that jumped off the page a little bit about. There were some gaps, definite gaps. Managing the chronic conditions, that's where almost every employer in the country has most of their spend is managing those chronic conditions. Unfortunately, in the state of Idaho, it is one of the top 14 in terms of least healthiest states. So you've got a number of things between COVID, where individuals postponed care during COVID, to medical inflation that's going on today, just like inflation in general, with a somewhat unhealthy population where 53% do not have access to primary care. It's why the model is something to seriously consider as a way to slow, reduce, and reverse much of that spend. Think also about the attrition and retention, the attraction and retention of employees. Imagine being able to access primary care, have your lab services, pharmaceutical services with no out-of-pocket. It's like a wage increase, quite honestly. It is generally rated first or second highest benefit by the employers we've served since 2005. So employees very much think that if they leave your employment, they leave that access. They don't have that access. They're subject to their $1,000 or $2,500 deductible or whatever is applicable. I'll go back. Last but not least, it's a little bit of a delay, sorry about that, is the injuries. Once again, it would just be a matter of being able to treat as many of those injuries in a lower cost setting than if they went to the hospital or a freestanding facility.
And with that $750,000 estimated ROI, we didn't factor any work comp related savings in there, so that would only be on top of, if you chose to utilize this for that.
I mention it only because to maximize the use of the medical team. So the medical team would be equipped to treat work comp as well as health plan medical issues. So in closing, truly since 2005, I started out as an underwriter for United Healthcare. I then went and managed a third-party administrator. It was about and then that led me in the early 90s into the on-site clinic model on the work comp side. And it was only in about 2008, 2009 did the employer community start to embrace primary care services as a benefit that they might offer their employees. So that's a little bit of my history, and I really appreciate your time. I'm passionate about health, so I hope that maybe this is something that we can generate some hard numbers for the county, and welcome the opportunity to go through with Sylvia and Leslie and Dorothy and Cece on more detail on the proposals.
Questions for Todd?
I don't think so. It looks kind of exciting, and I'd almost want to encourage employees to watch this and see if it's something they'd be interested in, and do that.
So I have a couple questions. So essentially, you're targeting the employee population that does not have a primary care physician.
Yes, it is ideal target.
Okay. Would somebody that has primary care, go ahead,
Yes, exactly, your question.
they could access it?
Yeah, both can do that. It's totally voluntary. We're not forcing any employees to change. It's just if they want to use this facility, there's no deductibles, no copays, no out-of-pocket. It's just their choice, but they're not forced to change doctors.
But the plan has to communicate or should communicate with the primary doctor, right?
If an employee, if I'm hearing you well, if an employee has a primary care doctor, our goal is not to disrupt that.
Right.
If they want to use this clinic because of the financial incentives, then we're certainly happy to do that. But anyone who seeks care at the employer-based clinic, we will share their medical information with any standing doctor in the community. It's very much intended to be a collaborative arrangement.
And when you say it's a dedicated team, a dedicated physician, my understanding is that they're dedicated strictly to Kootenai County.
That's correct.
So we're not sharing the services.
I have employers that do share, but in
Okay.
your instance, you have about a little over 1,700 participants, and that maximizes the time of a physician on those appointments. So this would totally be dedicated. It would always be the county's choice if you ever chose to open it up to other employers, for example, in the county. If you did, that might mean adding another physician, for example, to service them. It would never be about lesser opportunities for your folks. Every employee can sign on through their phone, through their app. They can walk in, they can call to schedule an appointment. This is about having an appointment tomorrow morning if you wanted one today, call in today. There's not about wait times. Whenever it looks like your employees are just overly using the clinic, then it's about expanding hours. It's about expanding access, not reducing it. Because you really want to engage people at a primary care level. Because a lot of times a specialist might provide primary care services, but the specialist is going to bill you twice what the primary care physician would. Or if you probably know the abuses of ER, urgent care, they're providing a purpose in the ER and the urgent care, but you're also going to go back and see your primary care doctor as well. So now the plan's getting billed both ways. So this stops a lot of that type of thing going on. And then if Scott's my patient, I'm talking to Scott in the 20, 40, or 60-minute appointment about lifestyle and behavioral issues that are contributing to maybe a chronic condition that Scott has going on. It's about taking it looked like about 43% of your population was pre-diabetic. This is about figuring out how to get those pre-diabetics to become more normal risk profiles and not the next insulin-dependent diabetic on the plan. That's the type of reversal. That's where the dollars start to come in from a savings perspective.
The possibility does exist of being an anchor plan. With the other employer that Todd mentioned, that's a mobile clinic, and it's kind of a unique situation, so it's probably not a good partnership. But we are talking to several other of our clients here locally about these services, and we'll be promoting this elsewhere in the industry. So the key there is we'll communicate with you if opportunities arise as to where we currently staffed, how's that working, does it make sense to maybe partner with another employer, and if it makes sense, we'll present it to you. And just simply to offset some costs, some fixed costs.
Do you have any of these models in Idaho right now?
We do in Boise.
Boise.
The Pacific Northwest was one of our more newer markets for us. So in Boise, about 3 years ago, we started with a group of employers there. And then that led to the Coeur d'Alene opportunity on the mobile unit, which has now led to talking to other employers here in the county. Is it Chris?
Yes.
Chris, it's not uncommon that if other employers in the community embrace, and let's just say they're on the northern side of the county or on the southern, that it's not uncommon it is common to have reciprocal arrangements where employees and dependents, if I live near one and work near the other, to be able to access that particular location, because the goal is to get as many people engaged as you can. And then we're constantly monitoring when more medical professionals are needed so that there's never a void in getting an appointment scheduled timely. It's a balance act that's managed by the clinic manager, and the clinic itself will gauge that and keep your benefits team informed. If you had need for a second medical professional, it's actually a great sign. That means that the 40% we estimated is more like 60 or 70%, which is exactly what you would want to happen at a primary care level.
Could you pull up the actual costs? Do you have that available? Just going off of memory, just for your information, there was a setup fee that he referenced. The dollar amount's roughly $300,000 setup fee up front, and then the monthly fees are around $90,000, I believe. Totals to about $1 million in monthly fees.
I only
about
have
1.3 million.
I only have the breakdown there about the numbers but I would truly share with you, because that $1 million investment is money that you're spending through the Blue plan today. I really like to just challenge you to think about how to spend that $1 million more wisely, is really the gist. Because if a person was going to their primary care physician today, they're being billed through Regents, right?
Right.
At generally a higher price point. So now, if they're going to the ER, it's coming to your plan and that. So you're really shifting dollars a little bit. So it's not 100% less being billed to the Regents plan, but it's not a 100% incremental cost to you, because it's being shifted over at a lower delivery point.
Yeah, so from an underwriting standpoint, it's difficult. It's not like a line item, apples to apples. They cost X, we're currently paying Y. That's part of it. They do have a lower unit cost on I think most services, is fair to say. But there's also savings through avoidance of ER. There's savings through disease management. There's savings from a number of buckets that add up to that $750,000. They have the credibility of 17 years experience and all their data from other employers, where they can validate that in their experience, they would estimate for you guys the savings to be about $750,000.
So the 43, if that's the 43% that don't have a primary care physician, what do your studies or stats show? What are they doing today? Urgent care? Emergency room?
ER.
I think three things are happening, Chris. They're either avoiding care
Okay.
until they absolutely need it, or they're using the ER, which you can't walk through an ER door for less than $1,000.
Okay.
Or it's immediate care use at that point, or it's a specialist providing primary care because, hey, you came in for specialty issue, but I'm asking you about primary care matters, so I'm going to go ahead and treat you. It's almost like 4 different dynamics are occurring on a daily basis.
Yeah. And one of the things I love about this is it can serve as a base for other services. Mental health in particular right now, it's nearly impossible to get in to see a mental health provider. If the need is there, and we could coordinate something even on a part-time basis to have dedicated mental health services just for your employees, staffed at this location, that in itself is going to save money on the medications potentially and possibly worse, down the road. So it's very flexible. It's not just a static, you're going to have a doctor, you're going to have a nurse, and away you go. It's, okay, what is going to benefit Kootenai County specifically? And what is going to benefit you guys might be different from the employer down the road, too. So it's data-driven.
So what do you need from us today?
Well, we'd
Be interested?
like a decision. Would the board like us HR, to seriously consider this going forward, and maybe how and how quickly? So
Leslie?
Well, we're a little full right now, so I don't see a problem going and doing more due diligence and doing that outreach piece to employees to see if they would be comfortable with this model. So I'm fine with that. I don't see this happening in 3 or 4 months. I mean, I just think we need to take it a little bit slower just because of our schedules. But, yeah, I mean, I think it's a good thing to look at for sure.
I think it's a great thing to look at as soon as possible. And the reason is, the sooner, if it does look like it's going to work for us, the sooner we implement it, the more savings there'll be, and the more we can return to the employees in terms of healthcare.
So I think to Leslie's point, the question is this something we could or have the ability to implement for fiscal year '23, which begins in October? And yeah, we do. We have plenty on our plate, plenty to analyze, plenty to consider. I mean, by all means, do you have any thoughts, Sylvia? Go forward with the analysis. Whether we'll be able to implement it for fiscal '23 is another question. I think that's what you're saying, Leslie.
Yes, and there's nothing to say that we can't implement it partway through the year. There's no, it would be, a fund, knowing that we'd have a fund balance cost up front, and then we would make it on the back end over the next few years. So this does not have to coincide with a fiscal year.
We could go calendar, which is what we do with
We do
Yeah.
Alliant.
with our health.
Yeah.
So proceed, I guess, if you're looking for direction.
For the employee communication, you were talking about getting some feedback. Would it be, would you like to do a presentation and have a voluntary, like a Zoom? Or how would you like to present that to employees?
It's all doable.
Do we even need it?
Well, I would direct them to watch this.
Yes.
Yeah, we
This
could do that
first.
first step and then see what kind of feedback we get from them. I think the communication going out will be critical to watch the presentation and then to give HR some feedback related to it. And then we go from there and see if we want to do some sort of a Zoom presentation for them or something pre-recorded. And then we can send them the link if that would work, would be
Yeah.
good. The more we can educate them, I think, ahead of time, so if we do move forward with it, then it'll get utilized for sure.
Yeah.
But I think it's a great model. How convenient and what a great benefit to our employees to have something near site for services. Then if we can build in some of that mental health piece too, that would be wonderful.
Yeah. Just to comment on the mental health side is that envision if there was a psychologist or psychiatrist even that came 1 day a week, for example, it would be a warm handoff from the physician to that psychologist, whereas there's a stigmatism to a person that generally goes to a mental health professional, where they would be right there in the same office. It's just an introduction, not like you even have to schedule an appointment. But then the psychologist can share with the physician what the underlying mental health, anxiety, depression issue is so that they can coordinate care a little bit. But it would be part-time. Envision just specialists like that coming in 1 day a week or once every 2 weeks, and they'd schedule appointments accordingly. And then that mental health care would be billed at a lower unit value than what happens in the private sector as well. Last comment on your diabetics and that, we would show in our reporting that the diabetics who are engaged in the clinic, the cardiovascular patients engaged in the clinic versus those who are not, we'd be able to show you how the cost of their care is lower by those who are engaged versus those who are not, which is a way to continue to encourage and educate employees to utilize the services. So,
Great.
Okay.
excited. Thank you very much.
Should we move on to the second item?
Need to make a transition here to Zoom.
Okay.
But, great job, Todd.
And this is an overview of Edison Healthcare Centers of Excellence Service with a proposal.
Correct. We need to transition to Zoom, and there will be a
Okay.
call in at 2:15. I can text him to see if he can join a little early, if we can get set up early. So,
Well, I mean, it's 8 minutes, so I guess
Yeah.
just work on getting set up and see if they can, yeah.
great. Thanks. Do we just unplug?
Yes.
I suppose we could even do recess for 5 minutes if you wanted to.
Yeah, we could.
You're welcome to stay.
I've got 2:07. Why don't we take a 5-minute recess, and then we can resume? Scott, will you be taking?
Yankees.
Hey, guys.
There you go. There. Yeah.
Okay, so this is the overview of Edison Healthcare.
Yeah, Sean, let us know when
So
you're
I just,
when you're on.
Yeah, if you all can just give me access, I can swing away.
Great. Okay.
There it is. Scott, do you want me just to go right into it, or did you want to do any kind of intro?
Great. Go ahead and pull up your presentation. Let me know where we're at, and I did a pre-intro, but this is Sean Rutledge from Edison Healthcare, highly reputable national vendor. These people were actually referred to us from our national analytics team out of Atlanta. When we for another client we were looking at, this other client had people in remote locations, and they wanted an entity that could help coordinate care and send them to centers of excellence where there's better access and better cost care. And in that process, we came across Edison and have presented to a number of clients. And it's just a great model, great potential. Again, totally voluntary on the county's behalf, but great potential on the back end. So with that, Sean, go ahead.
Yeah, thanks so much, Scott, for the intro. And like you said, Sean Rutledge, I'm one of the managing partners here at Edison, and I do a lot with Scott's firm around the country. So there's a handful of them that I take personal care of, and they happen to be one. So pleasure to meet you guys today. I'm going to give you a little history of the company, kind of how we got to where we are today, why we're in Tulsa, Oklahoma, of all places, and then sort of dive right in. And by all means, you can save your questions to the end. You can interrupt me. I try to take a really good pause so you have a chance to say something, but please interrupt me. It doesn't bother me in the least. So Edison was founded, late 2011 by a guy named Tom Emmerich. Tom is well known in the self-funded healthcare space around the country, around the world, frankly. He was an actuary by background, but ultimately started running global benefits for companies like British Petroleum, Diageo Foods, which is, Green Giant and Burger King and a bunch of others. And then ultimately Sam Walton, the founder of Walmart, caught wind of what Tom was doing from a Centers of Excellence accreditation and how he was managing his high-cost claims. And so Sam said, hey, Tom, come run Walmart's health plan, our 2 million members at the time, and install this program, please. And what was that? It was really founded on 2 core principles. First and foremost, acknowledging that 6% of the enrollees in a self-funded health plan are spending the bulk of your plan dollars. And what is that? It's what we call the outliers. Knees, hips, spine, cancer, heart, transplant, bariatric, complex pediatric, high-cost drugs. That's number one. Number two, we've got an absolute epidemic of misdiagnosis, overutilization, and inappropriate care in this country. And it's killing people, and it's killing self-funded health plans. So Tom said, okay, I'm going to take the 6% at Walmart, and I'm going to start directing them to the best centers, best providers under my accreditation protocols, to the best providers in the world that aren't doing those things. And by the way, we're Walmart. We can dictate price in the form of a case rate or a bundle that's far better than you'll ever get in a Blue Cross, United, Cigna, Aetna. Number one. And number two, we can dictate the diagnosis protocols with which they're required to follow in that actual hospital, following our rules, in other words. So sure enough, that's what he did. Saved the plan billions of dollars, continues to today, by the way. But what that did for Tom is it got him a lot of attention. Forbes, one of the top 10 guys to change healthcare in America, Harvard Business Review, article after article, best-selling books, etc. A bunch of employers started going to Tom and saying, hey, how can we get a program like this? We don't have the horsepower of Walmart, and we certainly don't have your expertise. And so ultimately the Walton family allowed Tom to clone what he created for them, and that became Edison Healthcare out of Cleveland, Ohio. Fast forward a few years, 2016, I've got my own little firm here in Tulsa that I started on my own, took off and did really well. Tom's been a friend and mentor of mine for a good 15 years, maybe a little longer at this point. He called me and said, hey, Sean, can your firm put some horsepower behind Edison's growth? I'm not a business development guy. I don't know how to do it. And so can you help us? And I said, absolutely. And we were very lucky, very fortunate to grow very quick. Some of the biggest brand names in America, from Amazon all the way down to the small self-funded employer down the street in Tulsa, Oklahoma, you've never heard of. And so what does that tell you? It tells you how we figured out how to work with the Blues of the world, et cetera. and work right alongside those plans. So really proud of that. Moved corporate headquarters to Tulsa, Oklahoma. That's where I live. We're Oklahomans, and we just continue humming along. Sorry about that. I don't know why in the world that popped up. So yeah, that's our history. Any questions at this point?
No, go right ahead.
Okay. Yep. All right. So you heard me say it. Small pocket of folks are spending all the money. I guarantee it. Well, I actually have your numbers, and that's in process as we speak. I'm actually going to show you what claims going through Edison will look like after we get done with this presentation. I think you'll like it. But I actually have your claims data, and we'll be putting together a formal proposal that basically says, had these claims in the last 2 years gone through Edison Healthcare, you would have saved X. And you know, with all the other things. So small pocket of people are spending all the money, but what do we know? We know that 20% of those folks will be completely misdiagnosed, and another 40% will have wrong or suboptimal treatment plans, which is a misdiagnosis in its own right. It's harming members, and it's costing employers a fortune for things they should never be paying for. And so what does that ultimately translate to in kind of real numbers? These are just a few of the things we do. Well, I won't read all of them because you can clearly see it, but I'll touch on a couple. 6 out of 10 spine surgeries in this country are completely inappropriate. Should never happen. They call them the cowboy doctor. It's a $500 billion industry. There's article after article about the notion that these surgeons have never met a back they didn't like cutting on. 30% of all cancer in Edison is misdiagnosed. This one frightens me a lot, frankly. I never thought I'd have this story hundreds of times over. You've been diagnosed with cancer in your local market. Maybe you've started treating for it. You go through our program to get a second opinion in the care if you need it, and you find out you don't even have it. I can't even believe that's a thing that happens in this country, but it is. Now, more often than not, it's wrong staging, wrong treatment regimen, wrong cancer happens all the time. The head of oncology of Mayo Clinic is a colleague, a friend of the company. And he said, Sean, 55% of the people that walk in our doors at Mayo Clinic with a cancer diagnosis have a complete and total revision in their care plan. That's kind of scary to think about when it's something so life-threatening. But you can see the others here, the stents and the bypass, et cetera. So I mentioned stents. 4 out of 10 stents in this country should never happen. This proves it. Dartmouth did a study associating cardiac stents with death. Now, who in a million years would have thought a cardiac stent and death were synonymous? If you all know what that is, simply put, it's a minimally invasive procedure. They stick a tube up your wrist or your groin. They go in, they check your heart out, they fix it, give you a medication, and you're out in a couple days. It's easy peasy. But we're over-stenting people in America, and it's direct correlation to death. The dark blue on this coverage map are the worst offenders. The subsequent lighter shades are just a little less worse. But check out Arkansas, that big blue blob near the central part of the country. That is one hospital in Little Rock, Arkansas that is killing people. And it is public knowledge. I'll give you some context. We've got a mall, Dillard's department stores is one of those kind of like Macy's or whatever chain. I don't know if they're up there where you all live, but they're in malls and stuff. Dillard's department stores happens to be one of our clients. They're based in Little Rock, Arkansas. We took a call from a gentleman there. The guy had 10 stents in his heart. 10 stents in 2.5 years, this facility. He was basically living there. They wanted to put an 11th stent in, so 11 stents in 3 years. I mean, what? There's no more room. I mean, seriously. So he heard about the Edison program through his employer, calls Edison, like, something's got to give here, man. I can't keep getting stented. What is wrong with me? And so what's funny about healthcare in America is all too often we take the most difficult roads to solve the simplest of problems. And this guy was a perfect example of that. The first thing our cardiology team, when they got his medical records, the first thing they questioned was the drug Plavix, well-known cardiac drug. Was it working from stent number 1? Nobody thought to even question that. So for $150, we swab the guy's throat. We run a pharmacogenomic test on him. Pharmacogenomics assesses how you metabolize the medication. If you're not metabolizing the medication, it's not working, period. We send it off to the lab. The lab kicks the report back. It's a super complex genetic report, way above my pay grade. But in the middle of that report is a red light, yellow light, green light of drugs you should and shouldn't take. Simple to understand. So in the cardiac category, the number one drug, red light list, never, ever, ever take this drug, was Plavix. So we switched the drug. He didn't need the 11th stent, and was informed by our cardiology team he likely didn't need at least 9 others. But unfortunately, healthcare in America seems to dictate where the money is. So you heard me talk about the cowboy doctor, the spine surgeon, $500 billion industry. We did our own study. So I'll draw your attention to the second and third rows here. Those are the most important. Patients receiving fusions per 1,000. National average is 43. You can see Edison Smart Care at 32.5 versus Hospital B that's doing fusions at 2 times the rate. So who's Hospital B? Well, Hospital B happens to be an Anthem, Blue Cross, Blue Shield Distinction Center, their term for centers of excellence, at 2 times the rate. Excuse me. Third row is the most eye-opening, however. Patients receiving 4 or more vertebrae fusion. First and foremost, this surgery is incredibly invasive. It should never happen, and it's almost always directly correlated to a redo or a revision, a screw-up. You got fused, we messed up, sorry, we got to go back in and open you up. National average is 7 per 1,000. You can see Edison Smart Care, that's our term for centers of excellence, at 0.63 per 1,000 versus Hospital B that's doing revisions at 27 times the rate. Not 27% more, 27 times more. So I asked a buddy of mine, I've got a lot of friends at Anthem and different carriers, just, past career stuff. And I'm like, how in the world could you allow this to be a center of excellence? It's a center of unexcellence at best. He's like, well, they have good outcomes. They have good infection rates. All the boxes get checked, right? That's what they typically do. But I knew the real story. I knew they didn't want to screw up their discounts with their providers because the providers are their real client of the carriers. They didn't want to irritate the employers, however, that just had to have this hospital system in their network to attract and retain quality employees. And then lastly, they were a Tier 1 center. So if you ever hear the term Tier 1 in Blue Cross, you get on the phone with customer service and they go, we have one of our Tier 1 centers. They're amazing. Tier 1, simply put, means they agreed to take a deeper discount in exchange for volume. So Blue Cross is motivated to steer that way. Now, I'm not suggesting every Blue Cross Blue Shield Distinction Center is bad because that couldn't be further from accurate. But what I am telling you is that their accreditation process, the way they select these centers, can be deeply flawed. And so this illustrates that perfectly. And this happens all over the country. This is just one example. So Tom has since retired. He's in the Ozark Mountains in Arkansas, kind of Walmart country, as you might imagine. But he would always say this at all of his speeches. The biggest quality issue is the least managed and the appropriateness of care. What's he talking about? Plain and simple, doctors are paid to cut. There's little to no performance management or accountability in healthcare, and it's killing people, and it's killing self-funded health plans. It's killing health plans in general. Just a few articles that speak to that very thing. There's a ton of them. I just picked a couple marquee ones. Handful of our employers, you heard me talk about Amazon, but we got a bunch of them, several hundred around the country and growing thanks to our friends at Alliant and other places. But yeah, just a few of those. So I'll pop through these next 2 slides pretty quick, and then I'll kind of get into the meat of it. How are we making this happen? How are we going against everything you've heard me say today that is wrong with healthcare? So we're assisting those outliers, the folks spending all the money, and getting the best treatment and advice in the world. We're getting the diagnosis correct. We're applying ethical surgical or other treatment solutions, which assures great quality outcomes. And then we're concierge medicine at its finest. So airfare, lodging, travel, the whole 9 yards is covered for patient and caregiver to go to one of our centers. This is a red glove, white carpet, or switch that, white glove, red carpet approach to managing patients. It's high-level concierge. So this is how we're doing it. It's these dots on this coverage map. I jokingly call us a PPO by disease, not by geography. You can't have a centers of excellence in every major community in America because it does not exist. These centers have gone through a 15 to 20-month accreditation process before they're allowed to touch a single one of our patients. This is what Tom spent a lifetime creating, installed at Walmart, and then we reinstalled it here. We've got a few others popping up, however. A couple in Indiana, one in Pensacola Beach, Florida. 2 more in Denver, 1 in Phoenix, and 1 in Texas. We figure we'll probably round out at about 30 centers before it's all said and done. But, we'll see how that plays out. So what if these centers gone through ultimately? That 15 to 20 months, yes. What does that come down to? The accreditation process is proprietary, but it comes down to 4 pillars of the process. And underneath these pillars are a million of nuancey things that we do to make it happen. First, speed to care. Very much, doctor, the patient will see you now. How quickly we get you from point A to point B. There are no waiting lists. We pick you up from the airport. We take you to your hotel. We pick you up from your hotel. We take you to the center where you're escorted every step of the way with a direct patient liaison. There are no waiting rooms. Second, multidisciplinary diagnosis. Understanding that all the things you see listed here on the left and the many other things that we do come with comorbidities. What do I mean? Maybe I'm there for my spine, but I have a heart issue. Maybe I'm taking lots of medications, overweight, diabetic. Who knows? It's important that a multidisciplinary team is managing every aspect of your care. So that's number 2. Number 3, 98+% of all of our doctors, our nurses, our oncologists, our surgeons, you name it, are salaried. They work for that center, they're accountable to that center, and they're accountable to us. They are not paid to cut. They are not incented to prescribe one chemo drug over another or whatever for the sake of the payout. So that's super important. Most of all, 4th pillar, we will never allow a single clinician or that multidisciplinary team, that pillar number 2, to be the final say-so on any decision made on any one of our patients and their diagnosis. They are required to double, triple, and quadruple check every decision, diagnosis made before a board of their peers that we have hand-selected in conjunction with them during that accreditation process. So why so many redundancies? Mayo did a study several years back, well, not several, like 5, I think, brought in several hundred of the best clinicians in the world, varying disciplines, for a blind study. Gave them all imaging, pathology, labs, whatever they need to come up with a diagnosis on a patient. They had no clue who the patient was. So they come up with their diagnosis, they all leave, they come back 90 days later. Unbeknownst to them, they're given the exact same patient. And I bet you can guess what happened. Come up with their diagnosis, and nearly half the time they changed it. Nearly half, the same person in 90 days. So what does that tell me? You've got to have checks and balances. I don't care what U.S. News and World Report says about you. I don't care what your education is. Human error is a very real thing. And that's why we have been so successful at managing patients and making sure we're getting the correct diagnosis while we don't have screw-ups. Super important. And I'll end with this slide, and I can, Scott, do whatever you want, show ROI or whatever you feel like. Structure, salary-based, you heard me talk about it, multidisciplinary diagnosis. All of our contracts are direct. It's carved out completely out of the carrier. These are our direct contracts with the center, and therefore they're your direct contracts with these centers. Outcomes, always monitoring our centers. Yes, that 15 to 20-month accreditation is awesome, but Sean, how do you keep tabs on them? Well, patient satisfaction being over 98%, patient reported outcomes maybe are the single biggest determination that a healthcare center is doing the right thing. Those all matter. But we also use a well-known accrediting body called BKD. They go out, follow our accreditation protocols, and visit our centers annually or semi-annually, depending on the volume they receive, the patient volume that particular center receives. So always monitoring. Wanted someone else saying we're doing a good job and not just us. Philosophy. It's really 2 things here. Evidence-based quality. Simply put, we will not work with an education facility, an education hospital. University of this, University of that, Johns Hopkins, Duke, you name it. They all serve a wonderful purpose. New technologies and research and, funding for new things and training of new doctors. I get it. That's awesome. You're just not going to do it with all my people. So what normally trumps evidence-based quality? What normally trumps patient care in an education facility? First, you heard me say it, research, funding, grants, money. So if you think about the very nature of that statement, it's tied directly to overutilization. If you don't spend the money, you don't get the same amount in the next year. And if you don't spend the money, you certainly don't get more of it. And so overutilization is directly tied to it. I'll give you kind of a little anecdote that literally just happened today. That's why it popped in my head. So Duke Hospital in Raleigh is the single biggest offender of inappropriate stem cell transplants in the world. It's not even close. You have a catastrophic cancer, you're late stage, it's a last resort. It's a $500 to $1 million claim. They do like over 500 a year. Well, they have a grant. They have funding for it. So we had a young lady go there. I got to say it was 3 or 4 days ago. No, last week. And they're like stem cell transplant. And so she was 27. And so we got her out of there, sent her to one of our centers, another center, because we didn't send her there, of course. And she didn't need a stem cell transplant. She had a very complex infection that was just a 2-week stint in the hospital, and she was going to be fine. Unbelievable. It's jaw-dropping. And I've got story after story about that, but I'll leave that be at this point. So anyway, what trumps patient care in those centers? Obviously, the grants, the funding, the money, training of the residences, the doctor wannabes, and then, of course, that placebo, that trial, that sugar pill, if you will. You can't do research if you don't have proper samples. Not going to do that with our patients. Always evolving, always improving, having our own TPA, having our own PD, and having all these things. And we're not here to talk about that today, but most importantly, listening to what our consultant partners and our employer partners are telling us. Where are their pain points and how can we fix it? Sean, we're getting killed on alcohol, drug, opioid addiction. We're paying tons of money to send these people to facilities. We're spending upwards of 6 figures, only to see them relapse 65% of the time. And by the way, the national relapse rate is 65%. Our program is, for example, $36,000 all in, and our relapse rate is just under 24%. So we're always listening, always wanting to be on the pulse. Lastly, price, financials. You haven't heard me talk about deep discount once today. Deep discount has never solved healthcare in the history of healthcare. Never once. We check the price box. Our case rates, our bundles are blowing, like I did say this earlier, are blowing the carriers out of the water, and it's not even close. But I'll end with this. Who cares about a deep discount on a surgery you never needed to begin with? And that's ultimately the true ROI with Edison Healthcare. We feel like the pricing is an obligation. So anyway, that's all I've got from a presentation perspective.
Any questions
done.
before we go into just a brief ROI cost example?
No,
Okay.
go right ahead.
Sean, can you pull up your ROI modeler?
You bet. Let me see if I can find it. I'm not the most tech-savvy guy in the world. All right.
There you go.
There it is. I'll blow it up a little bit. I kind of got ahead of you, Scott, and I remembered you sent me, at least at the time, the number of employees and plan members. So this is, let me describe it before I walk you through it. This is our validated proprietary ROI calculator, return on investment, validated by the Validation Institute, which is GE and Intel Care Innovations. I can conservatively tell an employer of any size what they will save by going through Edison versus their standard network, Blue Cross, United, Cigna, and the Pathway. We are outperforming our predictions with every single employer, and we're very, very proud of that. That's something that we have been able to stand by for the better part of 5 years. So let me explain it. So obviously, I got your name here. Can you all see this? Okay.
Yes.
Okay. I got your name here, obviously the date, number of employees. That's, if it's 755 now or whatever, it doesn't really matter. 1,700 belly buttons, our fee to offer this to you all. And then this predicts, now you may recall me saying, this predicts how many of these specific categories we expect you to have in a plan year. Like I said earlier, I'm going to take your claims data. It's in process. Scott and I talked about it this morning. I'm in the process of taking your claims data, your actual data over the last 2 years, I believe, and plugging that into this, plugging your actual cost and benchmarking it against ours. So this is the prevalence, and this is an algorithm. So it's normative data. And if you guys obviously know enough about healthcare to know that if you can normalize data in the healthcare world, you can predict. That's what an actuary does. That's why stop loss exists. They predict, and that's what we do. So we expect these things to happen. For example, you'll have a solid organ transplant 1 every 10,000 life years on your plan. That's the average. And I bet if I looked at 10 years of your data, it would ring true. Then the cost here is average national pricing. That is not our cost. That is average national pricing around the country. Nothing to do with Edison. We went really conservative on the pricing because we wanted to be able to benchmark our pricing and our algorithm for misdiagnosis, overutilization, inappropriate care, et cetera, et cetera. And so that's why we stayed pretty low on that thing. I will point out, just sidebar, our kidney transplant is only $80,000, all in. And I don't normally harp on price, but that's pretty eye-opening. And so I set the numbers. These are percentages. So if 100% of your population, small pocket of people, by the way, let me shrink this down now. If 100%, so 25 people of your total lives came through Edison, we would expect to save you $691,184. So that is conservative. You would pay us $63,000. The savings would be $627 with just 25 people. So let's go what we see on a voluntary level. And let me preface by saying this is the voluntary level when you all actually allow us to engage your membership. And I kind of draw a line in the sand on this one thing. I'm super flexible, but if you don't let us engage, if you don't let us perform our best practices for communicating, ID cards mailed to the home, push notifications if applicable, email blasts, lunch and learns, posters in break rooms if applicable, table tents, just allow us to interface so that they know they have this tremendous benefit in front of them that that your employer is giving you. So this is voluntary. So $351,374. Very conservative ROI, and all I need is 15 people out of your 1,700, and that's achieved. So anyway, that is the ROI. But like I said, I'm working on a more comprehensive one to show your actual data bumped up against ours, and I'll almost guarantee it. I don't want to just yet. That number will be much larger. So, yeah. So that is all Edison right there.
That's great, Sean. You mentioned earlier that Walmart makes this service mandatory. Is that correct?
Yeah, so the Walmart model in its purest form. Tom started with joints, and then he went to spines, and then he went to transplants. So, yes. So the simple way to describe that in the most simplest term is you go to Edison Healthcare, we pay 100%. If you go anywhere else, we're just not going to pay for it. Okay. That's a mandate. So what I always recommend, and Scott knows this, what I always recommend with an employer group that's never done something that aggressive, that you kind of baby step into that. You put some triggers in place like, waiving copays and deductibles, and unless there's an HSA, but then you do some, neat federal minimum stuff around that to incent them. Say, hey, we're going to pay 100% of this. It's best care in the world. It's a free service to you. And when the average American doesn't have $1,000 in their checking account, that usually resonates. And so there's that. And then kind of baby step into it. Start talking about it throughout a plan year. And then maybe start rolling out some things, especially when you see the analysis that I do for y'all here in the next few days. It's going to be pretty eye-opening. I've already kind of went through a lot of your claims data. I actually did that this morning after Scott and I got off the phone, just to get a sense of what I'm going to be looking at. I think it's going to be pretty compelling why you might want to consider mandating over the next couple of years. To make sure you're micromanaging this 15 people here or the 25 people, because it can really keep your renewals low. No 6 to 10% increase or whatever the number is. It can really impact the plan. And frankly, impact your stop loss in a way that I don't think y'all have ever realized. We have a number of stop loss carriers that discount if Edison is fully embedded, aggressively discount, just because they know Edison checks the price box, so that's good, but then it's what we're not paying for that's even better.
Pricing?
Pricing is,
Missing something
yeah,
here.
the price on this model is $7 per employee per month. And so it's basically a fixed cost of about $63,000. So you would pay that regardless, which, you know, in your budget of 12 million or whatever is a small amount. So the way I like to think about this is if we have one person utilize this program for a transplant, you're going to break even or save money probably. So.
Okay, can Sean share any of the names of any of the facilities that are part of the program?
Oh, sure. So, right up there, sort of in your neck of the woods, is Virginia Mason. And so when I say sharing facilities, I keep in mind we're doing very specific things within those facilities. We don't open the door to the entire organization. So Virginia Mason, Spines, Intermountain in Utah, transplants only. Beverly Hills Cancer, obviously, cancer. Chomp in Monterey, joints and spines. Mayo Clinic, best hospital in the world. It's not even close. We do transplants and other rare complex conditions. So that's one of the things that comes up when we build this relationship with the employer. We get calls for everything, just oddball stuff they need help with. So we're able to do so. The Andrews Institute, Dr. James Andrews. If you guys are, anybody in the room is a sports fan and knows that where professional athletes get their surgeries, it's him and his institute. So they're in our network. Cleveland Clinic in network. City of Hope Cancer in network. So there's several, and we are glad. We always share it. Like during this process, we're happy to send the list or whatever you like.
Interesting. Okay, do you guys have any questions?
A little bit. You're expecting a return on investment year one. Is that correct?
Yes, if and only if you follow our best practices. We do all the work. This is not a load on human resources, benefit managers, other than to simply review it and say, we like it. It's co-branded. The ID card mailed to the home is huge. Here's what I can honestly tell you. You give me 7, I'll hit that number. Just give me 7 people. One of the things that Scott had mentioned about our transplant, and I want to just preface this real quick, our most expensive spinal fusion, very expensive procedure. The highest one's upwards of $200,000. Sorry, my pit bull's up here. She's making a ruckus. Our most expensive spinal fusion. No, of course.
You're good.
Dog disagreed.
Sorry, man.
Yeah.
It's $62,000. So that is the high end. What most people who are prescribed fusions, you almost always either need physical therapy or minimally invasive laminectomy that costs $8,000. I mean, it's absolutely jaw dropping. So back to what you said. Yes, follow our best practices. Let us do the work for you. It always works. ID cards mailed to the home. It comes in the letterhead of the employer. It's branded to the employer. Obviously, Edison's brand's on there too. Outlining the benefit, what you all are doing for them, and this is how it works. Keep this card in your wallet, and when you have something come up, call them. So that is highly impactful. But then just the constant interfacing. I mean, we live in a world of smartphones these days. I don't care how old or young you are. Everybody's got one. The little notifications, the lunch and learns, the webinars, how to stay healthy. Those are things that we do. In fact, tomorrow I've got one with one of our employers in Phoenix, and I chose to take it just because I like to interact with members. And so I'm going to be talking to them about the benefit and let them know that I'm here My team's here, and we'll help you. Anything you could possibly need. It's not this presentation, of course. It's more member-centric, but anyway.
Leslie, you had more questions?
I think that's it. I think that this is something we can do for the next season. Would it start in January then, or can we start it earlier?
We'd likely start the communication process earlier, but probably implement for January 1.
Okay.
Okay, so Sean,
Yeah, we have a lot of employers that add us. Scott, I don't even think I've told you this. We have a lot of employers that add us off renewal because it's a benefit enhancement. So just food for thought. Whenever I was thinking it was 1/1 anyway, but I agree. Let's get that communication going. The problem will be this: you start communicating in September, October, whatever it is you do it. We're going to get calls, and that's okay. We'll honor it. We'll just have to have kind of a good faith. It's 1/1. We always call and get special permission to say, hey, Jane Smith is having an issue. She'd like some help. Can we go ahead and allow it? And then y'all say yay or nay on that. But we see that it happens all the time.
okay,
What is the lead time? What's an appropriate lead time to implement?
So we can do it very quickly, but you got to think about the entire ecosystem of the health plan. You've got the carrier, you've got stop loss, you've got TPA, you've got the consultants, and then you have the employers, most importantly. It's a matter of getting them all together to have the meeting. There's an implementation document. It's a PDF. It's a fillable PDF, easy to fill out, that you just, knock in all the categories. We have to have that before we can implement. Would take you all of 15, 20 minutes at most. There's, of course, the contract, the direct-to-employer agreement stating the $7 and all the stuff. That has to be signed. And then there's a BAA, which is common. That everybody's got one. So just the PHI and all that kind of stuff. So those 3 documents have to be completed by the employer and or consultant or however it works. And then it's a matter, then there's a few phases. There's getting all the operational components done. So we got to talk to the TPA. We got to talk to the carrier. Ideally, getting them all on one call would be awesome. Scott, if I recall, you told me that it's pretty favorable up there to get these types of programs on board, which will just make it easier. I could be wrong. I might have misheard you. And then the kind of that last meeting, really important meeting, is the marketing meeting, the PR, the best practices. And then I have a team of people that come on with you and do that. They're the 2 gentlemen that are assigned to your implementation. So in other words, about 3 weeks. The 2 gentlemen assigned to your implementation, we've done it in as fast as a week because everybody was just there. Are Spencer Blackwell and Will Johnson. They are assigned to your region, and they will always be your guys. The care engagement people, the people that manage the patients, are in your region, I believe, are Chelsea Plaster, Alyssa Ackerman, and Chad. Darn it, I can't remember his last name. That's embarrassing.
So, Sean, I've
We
got
got a lot of them.
I think a simple question. Okay, so somebody goes to their primary physician, has a condition, whatever it is, it doesn't matter. Physician determines that they need to see a specialist, and from there it goes to potential surgery, whatever it is. Where does Edison come into the picture?
Great question. So plan design, kind of what I mentioned, voluntary or mandate. So let's do voluntary because it sounds like that might be the direction, that you might be going. So all of those best practices, all of those communications, when John Smith's told, hey, you need a spine surgery, he remembers, oh, man, I've got Edison. I don't have to pay anything. I'm gonna call Edison and let them know I've been prescribed to see a specialist because they think I need a spine surgery.
Okay.
So that is the trigger. That is the trigger when you're told to do X. Now, in a mandate, it works a little different. Yes, all the best practices, all the communication still exists. We want people calling us. We don't want them to be told what they have to do. But, in the event they need to get something, we got to tell them. So now the trigger is this. They go to the specialist. And in the plan document, the plan that the document that governs the rules of engagement on your health plan, there's a pre-auth in there. And when that specialist says, "Yep, you need a spine fusion," and let's just pretend John Smith doesn't know, he forgets he has Edison. And so that specialist or his team, his or her team, call the carrier to make sure that he's covered, and it triggers it. You got to call Edison Healthcare. And that's how the mandate works. That's a very simplistic version of it, but that's basically how it works. There's a stopgap because none of these surgeons, they all have to pre-auth everything. They have to make sure they're going to get paid naturally. So when they call to make sure they're going to get paid and the member's covered, that's when it triggers. And more often than not, they're pre-authing that before the member walks into the specialist because they want to, again, make sure, even if it's a visit, that they're getting paid. So that's how the mandate works.
So that's where the best practice of communication comes in. If we had moved forward with a PMR, however, it changes. PMR can work on your behalf, be aware of Edison, and help direct and refer to them. So where the normal local doctors probably not. So,
Okay, so you're looking for direction for the next step?
yeah,
You're okay?
we're good on this one.
Okay.
So, unless you have commentary. So, okay.
Okay. Okay.
Thanks, Sean.
Yeah, thanks so much, guys. Real pleasure. Have a great week.
Thanks, Sean, appreciate it. We've got very limited time.
Yes, sir.
Any public comment? Hearing none, okay, I've got 2:54, meeting adjourned, thanks. Thank you very much, Scott, thank you, Sylvia.
Thank you. Bye.
Thank you, Adrian, appreciate it.
Goodbye.